Hi, my name is Adesua Akatulman. My friends call me Ade, and I am here to give you tips to succeed in your emergency medicine rotation. I'm so excited that you're choosing to do emergency medicine. I decided to do emergency medicine because I love that we get a chance to see a little bit of everything and everyone. And I can truly say that I learn something new every day, all while getting to make an impact on someone's life. And sometimes it's small, sometimes it's large, but the impact is always meaningful. So, congrats on making it this far in your medical school journey. And I know it hasn't been easy, but you absolutely have what it takes. You're already taking the first steps to make sure you get the most of your emergency medicine rotation by watching this video and the other videos in the lecture series. So by the end of our time together, I'm going to make sure that you have what it takes. You're going to be able to learn how to set the agenda to get the most of your experience. We're going to also go over the 6 steps to take to make sure you're successful during your rotation. And lastly, we're going to go over how to make sure you solicit feedback in a way that's effective and meaningful for you. So let's go. Now, it's important to keep in mind that unlike other specialties, the goal of emergency medicine isn't to just make the correct diagnosis. Instead, the primary goal is to never miss the emergency. So, even in cases where the diagnosis is clear, it's important to always communicate your knowledge of never missing the emergency. Now, to do this, I find that it's helpful to look at various frameworks for how to approach common emergency medicine complaints. Now, thankfully, we put together a whole lecture series of common complaints that come into the emergency department to help you do that. But in addition, I've always enjoyed sending my learners to the Foundations of Emergency Medicine website. Under learner resources, they have these frameworks where you can quickly review how to work up any issue that may come into your emergency department. For example, here's an example of a framework that you can use for someone who you're worried may be having an airway emergency. Now, in addition to strengthening your diagnostic skills, the emergency rotation is also an excellent place to hone your procedural skills. Here's a list of procedures that you may get a chance to do and or see while on your rotation. Now, keep in mind, this is from my experience of working in various academic and community settings, and keep in mind that every institution is different. So if you can, check with a current medical student or resident so that they can tell you which procedures you'll be expected to perform and ideally the location of where the supplies are. Now, once you have the list of procedures, there are plenty of places to find out how to actually perform them. Emergency medicine docs love our blogs and we love our podcasts. And actually, a lot of residency programs will have their own blogs. So I recommend starting there first. And then if you don't find what you're looking for, there are plenty of general ones out there that I've listed on the slides. My favorite ones in particular for learning procedures are EMRAP and Life in the Fast Lane. And I also like to use Dr. Smith's blog for learning how to read EKGs. Now, in addition to figuring out your diagnostic skills and your procedural skills, it's important to make sure you know your role. Keep in mind that the person you'll be working with may change day to day, and the teams you'll be working with will change as well. In the emergency department, most teams are broken up based on acuity. So for example, on team A, which may be the high acuity side, you may have sicker patients, you may have more trauma patients. And so as a result, the team is going to be much larger. So instead of working one-on-one with the attending, you may actually be assigned to a senior resident because the attending has to be responsible for everyone who's seeing all these complex patients. At the same time, you may have less patients as well because they're so complex, and you'll get the chance to do more procedures. On the other hand, say a team C or a low acuity team, you have less sick patients, more stable patients. And so as a result, you'll probably get a chance to work one-on-one with the attending because the team will be small. Sometimes it's just the attending and one of the residents. In this case, you'll have more patients that you see. And although you may have less procedures, you may get a chance to actually do more teaching. Here are some things that you can consider to do on your rotation so that you could be helpful for your patient and also volunteer to do this for other patients too. Again, keep in mind that each institution is different. So if you can, reach out to a resident or a medical student who can give you some site-specific tips. Emergency medicine is tricky like that because the role is constantly changing depending on the needs and the preferences of the team. And so as much as you can, try to prepare, try to be flexible. And if this information isn't given to you up front, just ask. Reach out to the coordinator. How are the different teams structured? And which member is responsible for working with medical students? All right, so now it's your first day and you're kind of nervous because we've gone over a lot already. All the diagnostic frameworks, all the procedural resources, figuring out your role, and it's hard to be convinced that you'll have everything memorized in time. I just said that your role is constantly changing, how you're supposed to keep up with everyone's expectations. So you're right, and this is what makes emergency medicine hard. Each day you're with a new team, with new rules, you're seeing different patients who can come in with any medical complaint. And it's difficult to really know how you can do this. So at the end of the day, if you take one thing away from this video, let it be this: make your own agenda. It's impossible to follow everyone else's rules. So instead, you have to make it clear to yourself what your goals are and communicate that with your team. Now, ideally, a great educator will ask you to share your goals. But if they don't, or if they forget, again, it's up to you to announce it to everyone so they can help you. I always like to tell my learners to aim for goals that are small, tangible, and attainable. I also recommend having just 1 to 2 and try to make one of them a procedural scale if possible. Finally, make sure you include an action plan for how to achieve these goals. Here are 2 examples of ways that you can communicate to your team how you plan to achieve your goals. Now, setting the agenda and stating your learning goals has to be my favorite tip for learners because 1, it puts you in control. You literally can prepare for what you're going to be evaluated on that day. 2, it makes you memorable. Oh yeah, so-and-so is a student who was really excited about learning about like neurological issues. And then 3, it actually allows for you to get meaningful feedback because you're going to get feedback on the things that you're actually trying to learn that day. And as a bonus, you'll be seen as a responsible, diligent, self-directed learner who's actually receptive and prepared to receive feedback. And I think a lot of times faculty are kind of afraid to give feedback to people they really don't know that well. And so setting your agenda really signals to them that you're eager and you're willing and you're ready to learn. Now, as a part of setting the agenda, the last step is to really check in with your point person and ask about any specific instructions they have for you, especially in the event of an emergency. And here's an example of how to do that. Keep in mind that even if you don't have emergencies, that's okay. Bringing this up is just a way to show that you want to be helpful to the team. Okay, so now we've gone over what to do about setting the agenda for the start of your rotation. And now we're going to go over the 6 steps to be successful while on shift. This slide summarizes the 6 most common things that evaluators are asked about when it's time to fill out those end of shift evaluation forms. And we're going to go through each of these one by one. The first thing you have to do is to perform a focused history and physical exam. And keep in mind that the key word is focused. And what are we focusing on? Not missing the emergency. It's fine to review the chart ahead of time. It's fine to check the triage notes. But after that, you need to make sure you limit your review to the most important things. For example, you don't need to know the last echocardiogram result of a patient with a headache, but it is helpful to know if they have a neurologist or if they have recent brain imaging. Honestly, if it's not clear from the chart right away, then you can just go straight to the patient. And if they don't know or if they can't remember, then you can go back to the chart for whatever details they're missing. In addition, You want to use your framework to help you focus your history and exam. And if you're not entirely sure, you can also ask for help. Here's examples of what to say to the patient and what to ask your attending for if you're trying to figure out how to focus your history and exam. Now, when going to see the patient, it's also helpful to know if someone is sick or not. In other words, do you have time to do the full history and exam? Or does this person need a life stabilizing intervention right now? If the triage note is concerning and or the vital signs are abnormal, then I always tell my learners to just go and see the patient right away. You want to see if the patient is awake, are they talking, are they smelling, or instead, are they sleepy, are they moaning, or are they breathing too quickly? After doing that, you can look to these examples for what to say if a patient is sick or if the patient is not sick, but had the potential to be so based on the triage note and their vital signs. Keep in mind that these examples show that you don't just go into the room of a potentially sick patient and not do anything. You don't have to do this for every patient, but for anyone who has concerning vitals or who looks sick, it's essential to communicate that you recognize that they're sick or that they have the potential to be sick. All right, so now you have a patient and they're sick. What do you do? Well, I tried to put a list of common interventions for abnormal vital signs that you can keep in mind. I also provided a list of common medications that you can give for emergent issues. I would take a screenshot of this and put it in your back pocket or leave it on your phone. Or if you reach out to me, I'm happy to email it to you. All right, so now the next step is to generate a prioritized differential diagnosis. Now that you've made sure that the patient is safe, it's time to figure out what your differential will be. This step is important because you really need to make sure you incorporate the results of your labs and imaging studies so that you know what the patient might have. A lot of times it can be really easy to just list 10 random diagnoses, but ultimately that's not helpful. So some people like to use this framework so that you first list the diagnosis that's most likely, and then you list the diagnosis that's rare or easily missed. And then last, you list the diagnosis that you can't miss. For example, in an elderly patient with weakness or fatigue, the most likely diagnosis would be an infection. The rare diagnosis would be anemia. If you didn't ask about dark or bloody stools or check a CBC, then it would be missed. And then the emergency diagnosis would be a heart attack. So an elderly patient with weakness and fatigue is almost always going to get an EKG. Okay, now the next step is to formulate a therapeutic, diagnostic, and disposition plan. Now, I honestly had seen learners who really had a lot of trouble with this because it seems like a trick, right? How can you treat something or develop a disposition plan if you don't know what the issue is? So instead, I see learners who just focus on the diagnostic plan and then just kind of wait to comment on the other parts until we really know what's going on. But you have to be okay with making decisions in the face of uncertainty. That's what makes emergency medicine different and exciting. A lot of times we don't know what the issue is, but that's okay because remember, the primary goal isn't to make the diagnosis, but instead to avoid the life-threatening issues. So we just base our plan on that. For example, for the therapeutic plan, you don't have to know the cause of someone's nausea or vomiting to treat them. Similarly, you don't have to know the cause of someone's fever to give them Motrin. For the diagnostic plan, it works in a similar way. A patient with chest pain is going to at least get an EKG or a chest X-ray because you can't miss the heart attack or the pneumothorax. And a person of childbearing age is going to get a urine pregnancy test because you can't miss the ectopic and you can't give them medications that are contraindicated in pregnancy. Usually the disposition plan is put in an if-then statement. So for example, if a patient is vomiting, then I am going to admit them to the ED However, if we can improve their vomiting with ondansetron and get a CT scan to evaluate appendicitis, then it's fine to send them home for, then it's fine to send them home. Here is a mental checklist. This is a tool called Rapid, and it essentially gives you a list of questions to ask yourself so that you can make sure you develop a comprehensive care plan for your patient. All right, so now that we've made sure that the patient doesn't need an emergent intervention, and we've done our history and physical, and we've gone through our differential, we've thought about our plan, it is now time to figure out how to present this to our team and to the patient. Now, the EM presentation is a really tough skill. And again, unlike other specialties, there's really no set rubric. There are so many examples about how to give a presentation, but the most important thing to emphasize is that you have to be concise and complete. And honestly, it's a really tough balance to master. So I always tell my learners to look at this article and this video, which do a really, really good job of explaining how to do this. And the biggest lesson from both of these resources is to really tell the patient's story in a way so that the listener knows the ending up front. You don't want surprises. You want everything that you say to point to the main diagnosis in your differential. Here are two examples. I'm going to go over two examples for you to think about. Now, the first one is about a patient who likely has a UTI. Take a second, look it over. And now this second example shows the exact same patient, but this time the UA results are back, and so we already know the diagnosis. Notice, compared to the first example, how in this example, the diagnosis is put up front and how the results are used to support your diagnosis. Also notice how the HPI and the exam are mentioned later as a way to discuss the differential and support the overall plan. Now, honestly, this is a really tough skill to master, and I'm still working on it. So the most important thing to make sure you do is to focus on being concise and presenting all the elements that support your final diagnosis. And if there's other information that you forgot to put in your presentation, don't worry, we'll ask and you just make sure that you have that. Now, once you've talked with your team, it's also important to make sure you update the nurse and the patient right away. Communicating with the nurse is essential because you need to make sure that the patient's care runs smoothly and that everyone is on the same page. And also, he or she may pick up something that the team missed or even teach you something you didn't know. Also, it's important to make sure that the patient understands and agrees with the plan. Because, for example, if the patient isn't able to stay in the hospital, then the plan changes significantly. And it's important to know that up front. Last but not least, it's important to reevaluate your patients and follow up the results. AKA, you need to make sure you own your own patient. Part of owning your patient means being able to help move the patient's care along. It's honestly really tempting to try to pick up multiple patients as a way to demonstrate your skill and help the team, but it's much better to see one patient completely instead of seeing two patients and forgetting to follow up on the test results and forgetting to update the family and forgetting to update the nurse, and things just get missed. Instead, you want to be the person to notice the results that you, for example, you want to notice that the UA result is back and you want to tell them that this patient probably has a UTI. You want to be the one to set up the ultrasound and do a cardiac scan and help move that along. You also want to be the one to evaluate the patient after they've received medications to see if their fever or their nausea or their pain have improved. So following up on the results and reevaluating the patient is the best way to be helpful. And actually, it's also the best way to learn. Here's some examples of things you can do and say to the patient and the attending to demonstrate this skill. Okay, so now it's close to the end of the shift and you are ready to complete your last step, which is soliciting feedback. Now, similar to the start of the shift where we talked about setting your agenda and making your goals, It's also important to solicit feedback in the same way. You want to avoid saying, "How did I do?" Because it doesn't always allow for the constructive feedback that you deserve. So instead, you want to reflect on your goals from the beginning of the shift and state what you think went well and one area or so to improve on, and then ask if they agree with you or if they have anything to add. Here's an example of how to do that. Now, the beauty of this tip is that 9 times out of 10, your point person will actually agree with you. This gives you a chance to really highlight your strengths, which is so important. It also gives you a chance to reframe your weaker areas as something you learned. And this is important because it shows that you're receptive to feedback and trying to turn your weak areas into strengths. Now, what if you're at the end of your rotation and you forgot to state your goals in the beginning, or the person who's supposed to give you feedback has already left? I just want to remind you that it's never too late to state your goals, summarize your performance, and ask for feedback. And honestly, it's perfectly okay to have the end of the shift being the same time that you mention your goals. And it's also okay to send it in an email. The most important thing is that you state them. So now we've reached the end, and you know how to set the agenda before your rotation. You know how to follow the 6 steps to be successful during your rotation, and you know how to solicit feedback after each of your shifts. Following these steps will put you in charge of your own learning so that no matter what, you'll always make sure that you benefit from your experience and become the amazing doctor that you've always dreamed you could be. I really hope this was helpful, and if so, please email me or find me on Twitter and let me know. Here's a list of resources. Again, I'm happy to share them with you. And I want to especially thank my NCSP colleagues for providing feedback on the talk. And I also want to thank the AAEM Justice, Equity, Diversity, Inclusion section for the opportunity to do this and share this information. I want to tell you good luck. You guys got this. And if you ever need anything, just reach out because we're here for you.